Hello, I am Dr. Venugopal, Head of the Department Emergency Medicine, Malabar Institute of Medical Sciences, Calicut. This lecture on acute dyspnea and emergency room approach. Dyspnea is a common presenting symptom for all ages in emergency department. It is present in emergency room like a non-urgent conditions to life-threatened conditions. It imparts long-term morbidity as well as premature mortality in patients. It a wide differential diagnosis to be considered in the initial management for a potentially life-threatening illness those patients present with acute dyspnea in emergency department. So this lecture try to define the dyspnea as such and explore the causes and its pathophysiology. The lecture also emphasizes on the unique emergency room approach in diagnosis and management of dyspneic patient and discuss the algorithm to manage shortness of breath in emergency room. What is dyspnea? Dyspnea is the perception of an inability to breathe comfortably, or it is an undue awareness of one's own breath. While discussing the dyspnea, we should also know few other terminology in relation to the dyspnea. The one is tachypnea. Tachypnea is nothing but it is the respiratory rate that is greater than normal. The second one is hyperpnea. Hyperpnea is a minute ventilation which is greater than normal, that is to meet the metabolic requirement. In contrary, hyperventilation is an increased minute ventilation which exceeds the metabolic demands. The dyspnea on exertion is the dyspnea which provoked by physical effort, and an orthopnea is the dyspnea in recumbent position. The paroxysmal nocturnal dyspnea is an entity which is the sudden onset of dyspnea occurring while reclining at night. How does the dyspnea happen? It is due to the derangements in oxygenation as well as acidemia, which in turn leads to the breathing discomfort. It also due to the stimulation of mechanoreceptors which is situated in upper airway, lungs and chest wall. And it also due to the stimulation of chemoreceptors which is situated in carotid sinus and medulla. Do you think that dyspnea is so common? Yes, one study shows that dyspnea is a chief complaint which made up of 3.5% of 115 million emergency room visits in USA. What are the causes of breathlessness? There are a wide range of differentials that cause acute dyspnea in emergency room. These differentials can be categorized under critical conditions, emergent conditions, and non-emergent conditions. A critical condition means which require very immediate intervention, and an emergent is slightly less critical, and a non-emergent condition which can wait for some time. So what should be the management priority in emergency room? Whatever the cause, the management priority should be addressed in an order like airway, breathing, circulation, disability, and exposure. The idea of this prioritization is an airway cause will kill the patient before an breathing cause kills. Similarly, a cause which originated from the breathing system will kill the patient before circulation, and a circulation cause will kill before a CNS cause, and a CNS cause will kill before the other causes. So the prioritization should always in this order, and all the focus should to identify the cause and manage it appropriately. The ER approach is unique because the focus is always first you identify, assess the patient and identify the risk. When the risk is identified, decide what is your action. Once you decide, act it. So assess, decide, act format should be approached in every phase of ER management in a dyspnea case. So what are the causes for the dyspnea? The causes, again, causes related to airway, causes related to breathing, causes related to circulation, causes related to disability or the neurology, and causes related to other areas. And these causes again can be a critical one or an emergent one or a non-emergent one. What are the causes, critical causes, which arising from airway? This include tracheal foreign bodies, angioedema, anaphylaxis, infection of pharynx and neck, then airway trauma, which include both penetrating and blunt. What are the critical causes related to breathing? Remember the 7 P's and 2 acute exacerbations. The P's are the pulmonary embolism, pneumothorax, that is tension pneumothorax, pneumomediastinum, pulmonary edema of non-cardiogenic origin, pulmonary infection, pulmonary injuries, and pulmonary hemorrhage. The exacerbations include acute exacerbations of COPD and asthma. The critical causes of cardiac origin include acute coronary syndrome, acute decompensated heart failure, cardiac tamponade, flash pulmonary edema, high output cardiac failure, cardiac arrhythmias, cardiomyopathy, and valvular dysfunctions. Critical causes in disability include stroke, including intracranial hemorrhage, neuromuscular disorders like myasthenia gravis, C-spine injury, particularly high C-spine injury. The critical causes in exposure include the toxins and metabolic, which include the poisonings like OP poisoning, paraquat poisoning, salicylate poisoning, carbon monoxide poisoning, then methanol and ethylene glycol poisoning. Again, the other critical causes which include diabetic ketoacidosis, sepsis, anemia, acute chest syndrome of sickle cell disease. The emergent and non-emergent causes include lung cancer, pleural effusion, intra-abdominal condition, ascites, pregnancy, massive obesity, hyperventilation, and anxiety syndromes. So, who can be dangerous in the management of acute dyspnea? To that, we should identify those patients in imminent respiratory arrest. The signs of imminent respiratory arrest include depressed level of consciousness, the inability of the patient to maintain respiratory effort, and cyanosis. The additional signs of risk or the imminent respiratory arrest include anxiety, sitting up, sitting blot upright position or in a tripod position, breathe rapidly using the accessory muscles, then sweat profusely, unable to answer the question anything with more than few words, then stridor or wheezing which may be audible. The signs of severe respiratory distress include the retractions and use of accessory muscle during respiration, then brief and fragmented speech, inability to lie supine, profound diaphoresis, dusky skin, then agitation and altered level of consciousness. The retractions, use of accessory muscle and cyanosis are the ominous signs, and they indicate extreme respiratory distress. Retraction in the suprasternal, intercostal or subcostal area suggestive of airway obstruction, for example in asthma, COPD and foreign bodies. And use of accessory muscle indicates that fatigueness of the respiratory muscles, and it is a potential for respiratory failure at any time. Cyanosis, obviously it is the sign of severe hypoxia. The combination of altered mental status and dyspnea, again very serious because it is the sign of hypoxia or hypercarbia. It also can be the sign of a toxin intake or an underlying pathology like hypoglycemia or sepsis. It is very clear that somebody is presented in an agitation. The first thing you should rule out is the hypoxia, and somebody is obtunded means it is likely to be a hypercarbia. So you should be cautiously about few things like dyspnea and hypotension are very ominous combination, and a dyspnea with a stridor, it is the sign of an obstruction. An inspiratory stridor, it is a sign of upper airway obstruction, and an expiratory or a mixed pattern of a stridor is a lower airway obstruction. A wheezing is likely to be due to an anaphylaxis, asthma, acute cardiac failure, or a foreign body in the main bronchus. So the questions continue. Diminished breath sounds indicates like tension pneumothorax or severe COPD or severe asthma. Crackles in the chest include or the crackles suggestive of intra-alveolar fluid as seen in pneumonia or in cardiac failure. The presence of a gallop rhythm is suggestive of acute left ventricular failure, and a distended JVD suggestive of a tension pneumothorax, tamponade, or acute decompensated heart failure. So what should be the emergency room approach? The emergency room approach should be very systematic and quick. The components of emergency room approach include a primary survey, secondary survey, ancillary test, and disposal. The components of primary survey include airway, breathing, circulation, and exposure. This primary survey is to manage the life threats and to stabilize the patient. Once the patient is stabilized, then you can do the secondary survey, which has two components. One is a focus history and other one is a head to toe examination. And to substantiate the secondary survey and the primary survey, you can do the essential ancillary test, and finally where the diagnosis and management is there, you can dispose the patient from the ED. Secondary survey means, I told you, it is a focus history and a HER2 examination. A focus history means it is basically a sample history. Sample history is a synonyms of symptoms, anaphylaxis, medication, past medical and surgical history, last meal, LMP and last tetanus, and event and environment. And you can also take essential social and family history. History can be elaborated by doing a PQRST analysis, and the history of dyspnea that can be elaborated like the P means the presentation, why it is which is the one is provocated, and how it is progress, and what was the quality of the dyspnea, whether it is orthopnea is there and PNT is there or stridor is there. What are the relieving factors? S for the severity and symptom associated. T is the treatment taken and any temporal variation. The severity can be assessed by box scale, which has got 10 points. Like 0 point is normal, nothing. 1 is just noticeable. 2 is just very slight. 3 is slight. 4 is slight but moderate. 5 is moderate. 6 is some difficulty. 7 is moderately severe. 8 is severe. 9 is very severe. 10 is a panic level, maximum shortness of the breath. Emergency management. Emergent management of dyspnea. This includes the management should start with oxygen, intravenous access, and the cardiac monitors. Though IV oxygen monitor is the cornerstone of emergent management, and this other emergent management include the airway management equipment is brought to the bedside because your patient can crash at any time. Do the screening examination for assessment of airway difficulty and search for a rapidly reversible causes like an upper airway foreign body, a tension pneumothorax, or a pericardial tamponade. A bedside ultrasound is always useful to rule out life-threatening issues like pneumothorax and a cardiac tamponade. While managing dyspnea, the life-threatening causes to be considered in all cases like acute coronary syndrome, heart failure, arrhythmia, pericardial tamponade, pulmonary embolism, pneumonia or other infection, COPD exacerbation, asthma, angioedema and anaphylaxis, poisoning like carbon monoxide, trauma in pneumothorax and hemorrhage. Three primary goals of emergent management in acute dyspnea are: optimize arterial oxygenation, determine the need for emergent airway management and ventilatory support, establish the most likely causes of dyspnea and initiate treatment. What are the pearls in the management of acute dyspnea? This include the initial decision to provide non-invasive or invasive ventilatory support is made based upon the clinical grounds, not on the laboratory values. Oxygen is a potent and readily available treatment for many causes of dyspnea and should be administered liberally. Potentially life-threatening causes of dyspnea should be considered in all cases. Endotracheal intubation and controlled mechanical ventilation should be pursued aggressively when ventilatory support is needed. Remember, IV line is the life. One caution should be there, like do not withhold oxygen for patient with COPD. The target oxygen saturation in such patient is 90 to 94%, with understanding that this may result in the hypercarbia and reduce the ventilatory rate. So consider the control oxygen therapy as far as possible. The ancillary tests that required in the management of an acute dyspnea, apart from the routine blood tests, and which include a portable chest X-ray, electrocardiogram, there's a 12-lead ECG, cardiobiomarkers like a troponin, brain natriuretic peptides, arterial and venous blood gases, chest CT and ventilation perfusion scan, then waveform capnography, negative inspiratory force test, etc. included in the test. So once you manage how you dispose your patient. So what exactly determine the disposition? This include look at that what is the patient condition. What was the preliminary diagnosis and what are the potential risks involved? When this is decided, your patient can be disposed either to ICU, to ward or observed in ED, or you can discharge at home. Who need ICU admission? Those patients with a severe disease, patients with rapid risk for rapid deterioration, and those patients who required close monitoring should be admitted in intensive care units. Those patients with less severe diseases but who fail to improve with treatment in emergency department with significant comorbidities and risk factors can be admitted in wards for further follow-up. The stable patients and the evaluation has ruled out significant diseases and the risk of disease is acceptably low, then you can send your patient home with discharge. The discharge advice should include clear understanding of the discharge diagnosis, and there should be a written discharge instruction, and there should be a planned follow-up with a clear instruction to return to ED if the patient conditions worsens. So here again you should be cautious about the elderly patient, that the clinician must consider such factors as the patient's living situation and access to medical follow-up when determining the appropriateness of the discharge. So what are the pitfalls in the management of acute dyspnea? The major pitfalls include failure to secure the airway in a timely manner, then failure to recognize and act on an abnormal vital sign and signs of impending respiratory failure, over-reliance upon a single finding to establish a diagnosis, then failure to generate a proper differential diagnosis, exactly the premature diagnostic closure, a failure to monitor the patient's clinical, failure to consider carbon monoxide poisoning or a pulmonary embolism in the diagnosis, the misinterpreting tachypnea, which may not represent a respiratory abnormality and may reflect non-pulmonary disease like metabolic acidosis or impending brainstem herniation. Other pitfalls include the patients with tenacious respiratory status to leave the ED and deteriorate in the radiology suite, and discharging the patient with inadequate follow-up or unclear instructions. The last part of this session to describe the algorithm to manage the dyspnea, acute dyspnea in emergency. Once the patient in the emergency room, assess is the your patient is in respiratory distress. If patient is not in respiratory distress, you can measure the SpO2, give oxygen, do a detailed examination, history, etc. But if your patient is in respiratory distress, do the IV, initiate IV, oxygen monitor and establish an EtCO2 monitor. Then look at whether your patient can maintain the airway and whether your patient is in respiratory failure. If he cannot maintain airway and he is in respiratory failure, you should initiate the assisted ventilation and look at the air entry in the chest whether it is equal or not. If it is not equal and there is a signs of shock, distended JVD, tracheal deviation, it is likely a pneumothorax, immediately go for needle decompression and tube thoracostomy. And if the patient can maintain the airway and not in the respiratory distress, go for the X-ray chest. And the patient with no JVD, not in shock, the air entry is equal, do a bedside, air entry is unequal, do a bedside ultrasound and decide whether it is a pneumothorax or a cardiac collapse. If it is yes, do the endotracheal ventilation, endotracheal intubation and initiate mechanical ventilation and do the needle crike on the chest tubings. And if the X-ray is once available, you should also do the physical examination and assess the breath sound and take the history and do the other essential physical examination. And if this shows like the blood lab is a positive BNB and the X-ray shows the interstitial pattern in the in the chest X-ray, likely diagnosis be the pulmonary edema. If there is a wheeze and the X-ray is normal, then diagnosis can be the anaphylaxis. If the chest shows the wrong K and decreased air entry and X-ray shows haziness, the diagnosis can be a pneumonia or an effusion. If the X-ray shows the unequal air entry and a history of the trauma, the diagnosis will be a large pneumothorax. And if the X-ray is normal and there is a history of chest pain, the diagnosis can be an ACS or a pulmonary embolism or a neurological event. If the diagnosis is a pulmonary edema, do the 12 ECG, initiate the diuretics, morphine and non-invasive BiPAP ventilation. If the diagnosis is the anaphylaxis, you should initiate the treatment with epinephrine, bronchodilators, steroids, antihistaminics or the anti-H2 and H1 receptor drugs. If it is the pneumonia, start antibiotics and send for cultures. And if it is a pneumothorax, go for chest tube. If the diagnosis is ACS or PE, then send the sample for a D-dimer. Once the D-dimer is negative, go for the 12-lead ECG, and if the D-dimer is positive, do an arterial blood gas study. And if the ECG is positive or negative, then you can send the troponin, that is a cardiac enzyme. If the cardiac enzyme is positive, diagnosis is ACS and proceed with revascularization strategies. If the ECG shows an S1 Q3 T3 pattern and right heart pattern sinus tachycardia, the diagnosis is a PE. And if the ABG shows an abnormal alveolar arterial oxygen gradient, then these two group of patients are the candidates for anticoagulation, then ventilation, perfusion scan, pulmonary angiogram and spiral CT. This is the algorithm in as a whole, and this is also the management algorithm. And in conclusion, managing acute dyspnea in emergency room is a challenging puzzle required a careful approach. A quick and timely intervention and appropriate treatment initiations are essential in the success story. A systematic and evidence-based team approach will resolve the issue to a great extent. Thank you for your patient listening. You can visit the website like www.drvenu.net, www.emergencymedicinemims.com. Thank you once again.